Okay, well, let's go ahead and get started. Welcome, everybody. My name is Norm Thirst. I'm the Executive Director here at NATO. Today's Hot Topics webinar, Interoperability, is sponsored by our collaborating partner, Verato. We're pleased to have them as their continued support as a collaborating partner. I'm going to turn the time over to Sara Herdman from Verato to introduce today's topic. Sara?
Thanks, Norm. I'm Sara Herdman. I'm Vice President of Product Marketing at Bari. And thank you to Norm and to NATO for inviting me to participate in this important discussion. Excited to be here. At Verato, our focus is the growing challenge of identity in healthcare and public health. Interoperability and identity resolution, meaning the indexing and assembling of a person's data from across multiple systems, often siloed systems, into a complete and trusted view of that person, are issues that we're helping organizations across healthcare and public health to tackle. And that I'm also just personally interested in and passionate about. So I'm honored and excited to be here as this panel continues our conversation on interoperability. Our moderator today will be Josie Bechara, Senior Research Methodologist from NORC at the University of Chicago. So I'll hand it over to Josie.
Guess what? Anna failed on.
Hello. Thanks so much.
Hang on one second.
Yeah.
Should be all set.
Now we need to get Josie to unmute. Sorry, Josie. There we go. Now
we're rolling. All right. Thank you both so much for kicking things off for us. It is a very exciting topic, and we're excited to be revisiting this in interoperability in today's hot topic webinar. That was a session that, as you all noted, as you can see in today's agenda, was something that we had discussed during our in-person workshop in May. And so actually members of the panelists that are included in today's webinar had either attended the session itself or the workshop. And so we've engaged in discussions either during the session or during the sort of overall workshop itself. And so as moderator, I wanted to encourage folks in the audience to share your questions and comments either through the chat box. And I see that since we're using Zoom as well, there's a feature where you could also raise your hand, and I'll try to call on you and sort of relay your questions and comments to the panelists. And so thanks, Sara. Actually, you summed up things very nicely as well with sort of your interest in interoperability. And I thought also to add to it, I'd share the definition on interoperability that we came away with from our May session. And this would be something I'd like folks, both in the audience and on the panel to sort of reflect on, come back to, add to, and maybe, sort of question if there are areas that maybe we might want to revisit. And that is, interoperability refers to the ability of data programs and systems to share or exchange data with each other or with individuals, such as providers or patients. And so successful interoperability requires conversations about data architecture, interfaces, and standards that allow sharing or exchange in an appropriate, secure manner. So that was the definition that we sort of formulated and sort of framed our overall discussions during the session. And so really, without further ado, I'd like to ask each of our panelists to briefly introduce themselves and then share a main takeaway from our May in-person event on interoperability that you would like to share with folks today. And so I'll kick this over to Lisa.
Great, thanks, Josie. So yeah, so just kind of adding to that, are we ready to do introductions? I'm sorry, I lost the thread here. Are we? Or just more about the summary of our experience at the conference?
Yes to both.
Okay, great. So I think many, some of the folks on this call know who I am and know who Civitas is. I'm Lisa Bari. I'm the CEO of Civitas Networks for Health, and we are a partner and reciprocal member organization with NATO. I had the pleasure of attending the in-person workshop with Josie and many other folks here, and we led this session on interoperability. And I think that it brought up some very interesting conversations about where folks were. People were in many different places. What my organization does is we bring together organizations that represent a variety of categories of sort of functional work happening, whether they're APCDs, other regional health improvement collaboratives, as well as a large group of the regional and statewide health information exchanges across the country. And we have organizations who cross multiple of those categories in different levels of development and maturity of the work. And so approaching the conversation of interoperability, which we talk about and work in all the time on the ACHI side, like very directly from the perspective of primarily APCDs and related health data organizations, was a really interesting approach for me to be part of and to partner with Josiane, because it brought into perspective, different places where the work is starting from. So I think that was the biggest takeaway I had from the session. And what was really interesting about it is that it was a different approach and a different take and a different starting point. And that's going to be really, really important as we make the conversation bigger. We have a conference coming up as well in August. One of the themes, this is like a preview for everyone, anyone who's attending, obviously a huge amount of the work in that conference is going to be about how all of our work affects health equity directly and indirectly. But one of the themes I'm going to be talking about is how the interoperability pie is only getting bigger. And we have to broaden the conversation, and we have to look at people starting from different places, different approaches, different perspectives, and understand that it's not in any way, shape, or form a zero-sum game. There is not enough interoperability right now, not even close. Units of interoperability are not sufficient for what we need to achieve as an overall, transformational and learning healthcare system. And so we've got to do a ton more, and we have to bring in people starting from all different places, and have to look at broader perspectives ranging from, clinical trials to, anything around different data sets that are not real-time clinical data sets to every other piece of the puzzle. And so we have to look at it from an abundance, openness mindset now and say, how do we get more people in this game? How do we expand and include and break down silos? And I think we talked about that a lot in the session. But evidenced by us having this webinar now, there's a ton more to talk about. So I'll leave it there for right now, but that's sort of where I left it in, I think it was May, time flies, in Seattle, and sort of our recent conversations as well.
Hey, I'll go next. Kenley Money. I'm the director of the Arkansas All-Payer Claims Database. And my key takeaway from the May in-person conference session, well, I like to be reminded that while linkage is required for interoperability, interoperability is more than just linkage. I led one of the groups on data linkage, and then shortly thereafter, this session was held, and it was a natural progression to go from one to the other. There are all sorts of folks are in all sorts of roles in this environment. There are those that are more externally and strategically oriented. There are the data geeks like me, and you have to use linkage and interoperability terminology and concepts to create the full picture. Interoperability involves, for it to be successful, it involves nomenclature and context, literal and figurative alignment of data to create information, and all of that will cross barriers. So I like to be reminded of things, and that's what I took away.
Great. I will dive in next. My name is Rob Lauder. I'm with an organization called Mercer, which is a multinational company that does all kinds of different things. I'm part of Mercer's Government Human Services Consulting Group. I work as part of an informatics team that's primarily focused on rate setting for Medicaid managed care organizations. But Mercer also receives, processes, and analyzes lots of data for other state entities, providers, and vendors. When we were in Seattle, my group discussed the incentives around interoperability. I found that was really interesting. Hospital A can share an MRI result with Hospital B. That would lead to an overall healthcare expenditure decrease, and the patient gets to skip, the additional poking and prodding. However, if hospital A receives that copy of the MRI, then they're not going to get to run their own MRI, and they miss out on an opportunity to receive payment on that. They're just less likely to really want to expend a lot of resources on interoperability because it might negatively correlate with their own bottom line. Similarly, the other hospital has less incentive to want to share that MRI result as well. They want to keep the patient with them instead of transferring to that other facility. And so even beyond the technical details, interoperability is really complicated at just aligning the incentives to make sure that organizations are incentivized to work on this in the right direction. So that's me, and I'll pass it to Kyle.
Great, thanks, Rob. Happy Friday afternoon, everybody. So my name is Kyle Russell. I'm the CEO at Virginia Health Information, or VHI for short. The easiest way to describe kind of the collection of different services that we provide, we administer statewide data collection, exchange, and reporting programs for the Commonwealth of Virginia. That spans a bunch of different systems, including the Health Information Exchange, All Payer Claims Database, and several other systems that we've accumulated over the years. So I was at the meetup, but I was not at this session. So I had to think a little bit more abstractly about this concept. And admittedly, kind of my feelings on the subject have changed quite a bit over the past couple of years. I mean, I think that anytime, as a state-based organization, right, like anytime you're advocating to say that we should collect data like in a more segmented way because we need to specialize around a certain item, which inherently collecting data at a state level is that. If you can't put the parts back together later on to ultimately say, yes, we can collect this more segmented, but we can put it all together and still benefit from that overall data collection, then that's kind of a problem, right? And so you have to solve that to really argue and say, this makes sense on how systems should be set up. And admittedly, I feel like a few years ago, I was like, like data linkage and some of this, like, I don't see the short-term value proposition on some of these different projects. Like, I don't really get it. Versus now, I feel like it's not taken that long to see, I feel like where we sit of like the data, like the interoperability and the linkage of these different systems and benefiting from the net whole of having these different collection systems, like that's probably our primary value add to the Commonwealth of Virginia moving forward. So I've definitely done a 180 on that, and I heard that the session at the meetup was tremendous, very well moderated, I heard. So.
Great. Thanks so much, everyone, for kicking things off with intros and your main takeaways. As I've noted in the chat box and initially too, that we would really like to have this an engaging session. So that is, if folks in the audience have questions or comments that they want to share with us, we would like to respond to those and talk to you further about your thoughts on this interesting and engaging topic. So with that, maybe to sort of warm things up, I'll throw out a quick question to you, Rob. And then I know that a few of you have also reflected on it, both in your intros and also in our conversations throughout leading up to this webinar. And, which is basically, what are some of the interoperability related challenges? If you could continue to talk a little bit more about that, that you're seeing at the separate provider, state, and patient levels.
Yeah, thanks, Josie. So to dive into the provider level first, I had three that came to mind. First is the technical, just getting the systems to talk to one another, using a consistent meaning across those systems, consistent formatting. Got to make sure that we can work through all those things. It is a considerable challenge. The next one is legal. There's certainly a lot of uncertainty of what information can be shared between organizations and making sure that we're aligning with HIPAA and other standards. Could be some confusion at state level, local level, different things like that. The third one for the providers is just aligning those incentives, like I spoke about a little bit before, making sure that the patient is going to be put first and make sure that they're going to get the best possible care, trying to prioritize those things, work through the incentives too, to make sure that the hospitals or other entities that are involved are going to benefit and that they really have a positive outcome from being involved with interoperability. Moving on to the state level, I think knowledge is really important, just getting to understand everything about interoperability. How can it be beneficial to patients and providers? while still making sure that we protect the patients and that the information does not get distributed to where it shouldn't be. There's a fair amount of risk with that distribution, and I think that risk then can be very confusing to state entities. Making sure that you're managing the risk effectively, using a good understanding of interoperability and the benefits to evaluate where is there some risk but maybe is worth pursuing, where might we want to avoid because there's little value, and where is there little risk and we can dive right in and try and gain as much value as possible. The third one I have for the state is decentralization and just aligning the incentives for the market to solve problems. We don't want these interoperability systems to be built on a small number of companies that may be very open, very interested in building an environment, being very helpful there. But then, as we move forward and try and progress the systems, maybe there starts to be additional barriers for those small numbers of organizations. So we want to try and keep the marketplace open. Want to try to keep many people involved, not keep it limited to a small number of companies. Moving on to the patient level, again, I have three here. Education, making patient education accessible is a great opportunity for interoperability, putting information out there for patients to access, making sure that's in an accessible format, that the patient can find what they're looking for. There can be so much information sometimes. Secure access, protecting the patient data while still allowing them access, definitely a challenge. We want the patient to be able to access their things, but then make sure that their patient is not themselves accidentally sharing that unintentionally, where it shouldn't be, and making sure that they're aware of how to keep it secure. And then multiple entities sharing as well. Trying to just keep direct patient involvement with multiple entities that are involving this data, providers sharing with pharmacies or dentists, pulling in that information across all the different healthcare landscape.
Great, thanks, Rob. I was wondering, Lisa, I know that you opened actually with some of your takeaways that intersect with some of these challenges that Rob had noted, and you had noted about how we need to do a ton more and look for broader perspectives and break down silos. So I was wondering if you had any thoughts to add as well, based on your experiences and where you're at.
Yeah, absolutely. Often in the HIE world and broadly in health IT, if you just think of like the health IT landscape, especially clinical health IT, let me be more specific, clinical health IT, I often say there are no more or significant technical barriers to interoperability. There's plenty of organizational barriers, just to be clear. There's plenty of competitive reasons why somebody might not be interoperable or exchange information, but these are like known technical challenges. When you start to expand your aperture a little bit more and you look into other domains, into areas of administrative data, into human services more broadly, into SDOH, into other areas, I don't want to say that there are no technical challenges, because there are technical challenges. There are absolutely challenges around nomenclature, terminologies, formats of all kinds. I know, especially in the APCD world, you all are extraordinarily familiar with format issues that are really timely, really, time intensive and costly and very difficult to resolve on an enterprise scale. So there are more and more technical barriers, but we still come down to the idea that where there is organizational, governance, government, motivation for interoperability and exchange to happen, it will happen. But you do start getting to a place where you still have more of these transaction costs. So what can we do over time to start bringing awareness to the transaction costs and the difficulty? Again, it's not technically impossible or infeasible, it's just incredibly costly. And that is a barrier, right? You don't have unlimited money, unlimited time. And how do we start making some of the gains that we've seen in clinical health IT interoperability in broader context? So I think that's kind of what I look at, is what are the highest priority silos that we can start to break down, and what are systematic ways that we can also start to reduce the transaction costs for interoperability between and outside of clinical health IT into other worlds. Because I think the promise of Civitas and our members coming together broadly, including NATO, including many of NATO's member organizations, is the idea that we'll really start to be able to address truly whole person care that's not just in one clinical health IT domain, but in a much broader domain and setting. And we can't do that if we don't start breaking down some of those really high costs and silos that exist.
Thanks, Lisa. You know, what you were just also mentioning about going beyond the technical barriers, I know, Kenley, you also reflected both in your intro and also I recall a lot of the conversations around during our session at NATO. Also, you're sort of looking beyond, you know, accepting that, yes, there are technical barriers that are known, but also, you know, going beyond that, that there's also things that, you know, go into like more the area of governance and, as Lisa noted, government. And so I was wondering if you could maybe share some thoughts there and also some reflections on your own experiences at ACHI.
Absolutely. Yes, thank you. I agree with Lisa, absolutely. We get better and better at the more technical aspects of linkage systems, interoperability between systems, etc. But we find, and I'm repeating a bit, but we find the challenges in different organizations understanding what the data is and what the systems are and what the value of it is, quite frankly. And I read that we could categorize that there's foundational interoperability, which is like data exchange. Those hurdles are being conquered every day. And then there's structural interoperability, which is our formatting, the CDL, the APCD, common data layout, any layout in any system. And then there is the more esoteric one called semantic interoperability. And in my shop, because I run the all-payer claims database, I'm more inwardly focused, but still we have to build data assets that serve external customers and entities, and more importantly, provide information to help health policy decisions. So the obvious need for a common set of terminology and a clear understanding of what things mean across organizations, across sources, across whatever is critical, hence interoperability. So we work very hard to structure our projects and our analytic projects and our data build projects, et cetera, to utilize best practices, not only for technology, but for terminology from solutions across the country. I will selfishly say I use NATO a lot for that, to know what everyone's doing. But the definition of a provider over here could be different than a provider over there. So we're working on a project right now to build a master provider file. We all want that. It's almost a unicorn, but we're going to give it a shot. And so there are board data files, there's the MPI file, there are data provider files built by others as our own APCD data. And we have to align. We're starting, I'm not even worried about mapping fields, the structural, the foundational. I'm not worried about that at all. I'm starting by working with these organizations to understand what the definitions are. When they say a specialty, what does that mean really? And how does that overlap with the specialty from the NPI file? And how does that overlap with the specialty from this and that and the other? And we're going to build a common, you could call it a data dictionary, but certainly it's going to be a common way to say it. And we have found success in other projects by being first in naming things. We can establish the nomenclature. We are going to define specialty this way, not different. I mean, it's going to meet everyone's needs, but if we start speaking that way, and we have found some success in that, where we ultimately build that level, that new foundation. So how do we do that? Finding the projects, that's pretty easy. We all have projects that need that. But how do we make it successful like that? Well, creativity, a little bravery. It's always helpful if the directors of the organizations you're working with are brave as well. But the biggest key to success is continuous improvement. Don't ever stop looking. Look at it again and again, apply new data uses and again and again. And that's what makes these things work together. That's been our success.
Thank you so much for those reflections, Kenley. Yeah, I know, I mean, understanding, well, appreciate you sharing the resources. And that's something that I was hoping that folks can also continue to sort of think about, like people who are looking to learn more about interoperability, where are areas that people can look and learn more about how that could apply in their organization, or steps and best practices to learn from. So that's helpful, NATO being a wonderful resource to folks. Another thing too, construct definition is definitely key and like the starting point in many ways, and trying to make systems like understand each other, starting with like, how are these systems defining these concepts, and how do you want to start defining them as well moving forward? So that's really helpful in terms of how you're also approaching that and your other aspects of your project. I know we've reflected a lot on challenges right now, and I want to be also mindful of time, and also again encourage folks in the audience based on like what you've heard today and what you really want to hear as well, to reach out, you know, via the chat, or again like raise your hand via Zoom and share that. I was hoping maybe as you know, folks reflect on that, maybe we could transition to talking a little bit more about some of the benefits and the value propositions, Kyle, that you were talking about earlier in your introduction, in terms of the short-term and the long-term value proposition for interoperability. I'd like to hear actually a little more about, you know, your reflections of how you transitioned to understanding the value. Like, what was it? What was the junction? And sort of what were some of the areas that you saw that, could definitely benefit from better systems for interoperability?
Right. I think that there's sort of like the value out of the systems themselves, like I would say maybe more like benefits that we would provide as an organization, and there's more like societal healthcare benefits. I think within how we think about like how we would add more value via interoperability, it's like most collections or exchanges that get set up have a primary benefit, and then they have secondary or stretch benefits, right? Like I'm sure everyone that's operating in APCD would say, all right, there's 3 or 4 things that we are the best source for that we can answer really well. And then there's a lot of requests that we get where it's like, you can use this system for this, but it's probably not the best collection, or there's going to be a lot of weaknesses. And so I feel like by setting up systems that can connect more well together, you can make better use of the primary value add or the primary use case that drove the systems being set up the way that they were to work together. And so you're not having to venture as much into the stretch use cases of a system because you're using it in isolation and saying all my eggs have to be in this basket of APCD or an ENS system. Second, I mean, the societal benefit I feel like is pretty clear, right? When you don't have proper data exchange or access, then when there's less access to information, you have to make more assumptions. And that's going to result in a lot more unnecessary testing, unnecessary services for patients, like less informed diagnoses. That additional information, less information have to plug in from the patient. But so both from like a safety, from a lifestyle, from a cost perspective, like breaking down those barriers to do it, I do think is hugely beneficial. But I do want to say, just sort of following up the limitations, I mean, there's a reason why this process takes a while to do. Like, we are kind of going against the natural flow of things. I mean, probably the most common way to set up an organization that added value is to get exclusive rights to something and then put a silo around it. And we're guilty of that too. I mean, it's not even just like, oh, let's beat on the big vendors or health systems that do this. Everyone kind of has a little bit of having to deal with that, of like, how much am I adding value over what something should be a public good? And so it takes a lot of collaboration and time to do that, because like I said, it is difficult and kind of how things are set up, with everyone having to kind of go out and figure out their place in the world. So, but overall, I think we're definitely trending in the right direction.
Thanks so much, Kyle. That's helpful. I was wondering if other folks would like to weigh in on the benefits of interoperability.
I mean, I can sort of chime in here a little bit. I think that, you know, sunlight is the best disinfectant. That's maybe kind of a pointed, not very kind statement, but I think that, you know, we have so much, there's so much incredible sort of waste and poor quality healthcare in our system, right? Just issues of unnecessary, unneeded spending is one. Quality, sunlight on quality. We won't truly understand quality and outcomes until we have interoperability of data and information and systems, right? We have little views, little snippets here and there, little views into a silo, and we don't have the whole picture. And we know sort of intuitively, or, you know, those of you who are also in clinical care, you see it all the time as well. You know that these things are happening, but it's really hard to make a clear case to drive action. And you need to see the full picture to be able to, you know, make up ultimately policy changes and make your case and advocate for what we know, what we believe from our experience needs to happen in the healthcare system. So I think that ultimately, and that's what you see, right? You see where you see competitive challenges sort of blocking efforts for interoperability and exchange. It's because hospital system A, you know, doesn't want to share with hospital system B, who is their direct competitor. You know, always, my brain always goes to like the famous hospitals in Boston who are across the street from each other and don't share information because they are competing. They're competing for patients and lives and data, and they're competing for data. And that's, you know, just really a bad outcome for patients and for our entire healthcare system. And I just think that, you know, ultimately it's a question of, if we are really serious, if this group of people here and in the broader Civitas community and in our, you know, peer communities are serious about making these changes, we have to ultimately drive for interoperability of systems and data and solutions, because it's how we get the information and shine the light on what's really happening. So that's kind of my semi-provocative answer to say that it forces competition on outcomes, not hoarding of data.
And to add a little bit about benefits to patients, just talking about some ideas of how interoperability can lead to improvements there. If we can have a provider and a pharmacy system talk to one another, then before the patient is dispensed a drug that they might be allergic to, the systems can interact and we can update the drug that they were going to be given and get them one that they're not allergic to. So I'm kind of stepping in there between the different systems can improve outcomes like that for the patient. I talked a little bit earlier about sharing scan results or tests, different things like that, prevent duplication of services, also making the patient get a little bit less poking and prodding, in certain cases, less radiation. That can definitely be good. Easy ways through our interoperability, we might be able to keep track of patient vaccinations and make that accessible. It's a common thing. I don't know exactly the last time I got my tetanus booster, but if we can put that into a system where my new, PCP provider can pull that up and take a look at it, they have it easily accessible from previous physicians, just allowing the information to flow across the different organizations. Another one, last one here from me, integration of behavioral and physical health treatments. Considering some drug interactions, maybe a patient is receiving something for a behavioral health or substance abuse treatment, and that might interfere or interact negatively with a physical health drug that's being considered. Different treatments, the way they interact with one another, allowing the systems to talk to one another can create a more holistic care environment, preventing more negative correlations.
Josie, I have something to add. Something that you said, Rob, made me think of a success that I'm going to consider an interoperability success in Arkansas at the semantic level. For many, 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 many years, actually, the genesis of it was in 2003. An act was passed in Arkansas called the Child Obesity Act, and it was to begin to put systems in place in the state to understand how much childhood obesity there was and how to fight it. And until 2 years ago, the Arkansas Center for Health Improvement, the group that for which I work, we managed the data input systems for all the public schools to enter childhood obesity. And there were protocols, and kids of different ages and systematic schedules would have the BMI readings would taken every year, and then it would be entered in the system. And ultimately, ACHI would produce a report that, an analytic report that was the report card, though much deeper and denser, of childhood obesity throughout the state at the school and district level. And I say all that to say that over the years, the Department of Education in Arkansas used that report and learned from that report, and they recently acquired a new technology that incorporates all childhood tests in one system with definitions largely influenced by what we did. So the children can now get a student health report, which not only includes BMI, but also includes vision, and it was the vaccinations you were talking about. That's what made me think about it. And that is, this system also contains disciplinary actions and absenteeism, and it builds that picture for student health. So that I want to put that up as a success of many systems that were independent and then came together.
Thank you all for your reflections on that. And actually, we have a few questions coming through the chat. Thank you to the audience for reaching out about that. And I know, though, we're coming sort of to a time, but I did want to try and have panelists reflect on some of these questions. The first being, how do we increase interoperability, coming from Arya? How do we increase interoperability in a patchwork system such as vaccination at CVS, Walgreens, making it into patients' main EMR?
That's an area we've made a lot of progress, right? I mean, I think most states have IIS systems that bring the data in, and then most patient EMRs should be able to connect to that system to get the data to flow in. I think it works better in some states maybe than others. And then I know I've personally been able to tap into that same vaccination data to be able to provide like practice managers and say, hey, for your whole patient panel, like here is vaccination data from yesterday onward that has it. So not to say it's perfect. I mean, I think it depends on the systems, but the IIS systems have come a long way, I think, and I think are fairly interoperable with most EMRs, probably not all. But.
Just one thing I want to add to that too is that I think the insurance companies can have this information already as well. And so sometimes it's a matter of they collect it, but they need to maybe distribute it back to the other providers to spread the information around.
Thanks, Kyle and Rob. Oh, Kenley?
In Arkansas, we don't get not all vaccinations generate a claim. So there is a gap, and it's hard to use claims data here anyway to bridge that gap as described in the question. The vaccinations have to be reported to the health department and from everywhere. And then if we can get them, that's where we would get them, as the one picture. So, and they have yet to give that up. So clearly there's another interoperability barrier we have to overcome.
Great. Actually, Kenley, I was wondering if you want to also take the next question on there, which is how can we increase interoperability across health disciplines where coding nomenclatures may differ?
Oh, you gave me the hard question.
Oh, no. I was just reflecting on your project, but yeah, sorry.
Does I don't know count as an answer? I'm going to reiterate and sound a little cliche, but it's about communication and transparency and showing the value add, which is the hardest thing. And it's an easy thing to say, show the value add. But sometimes it can be helpful if you illustrate the barriers to be able to overcome them.
just to add to that, I think standardization would be ideal. You know, that's not necessarily something that it's easier said than done, I realize, but you know, how can we make things more consistent across the different health disciplines?
That's fair.
And for behavioral health, that's, I mean, I don't know if it's going to lead before you see for part 2 clarification. I mean, that's a huge factor. Like that information is not being shared to the same degree because they're, you know, rightfully so. There's just a lot more hesitancy around, you know, concern about misuse, consistent with federal regulations on that. So, I mean, I think on that side, I mean, with dental, like, I mean, I can only speak for Virginia. I mean, our centralized dental collection compared to medical or pharmacy is like so far behind. It's not even close. And so it's like we don't even have data to like make interoperable with some of the other systems. So I think it depends on the state. I mean, I think we're probably behind in Virginia for some other states, but like we got to get some from a centralized perspective. I have to get some data to exchange, I think, with it. And then I guess probably from an entity to entity, I mean, I guess it's tricky. You probably have vastly different EMR systems. I don't know. I'm not an expert, Shereen. I think you probably know a lot more about that than I do, but it seems like maybe one is a little bit clearer to me than the other, at least what the primary issue may be.
Thank you all for taking that hard question. I appreciate it. Dental is kind of central to my organization's mission, but we're trying to branch it more towards comprehensive health. And when you're talking about folks with chronic disease and talking about medical dental integration and behavioral health integration, well, the clinicians really need that. The dentist needs to know that this person in their chair has the condition they have because they're on these psychotropic medications that have an impact on their teeth, and vice versa. You know, if they have an abscess, you may not be able to get a kidney transplant. But how can we better make sure that they know these things when we're kind of using different sets of codes? So thank you for tackling the hard question, everyone.
Thank you all. I know we also have a few questions coming in. However, I just wanted to check in with Norm on how things are looking. I'm wondering if maybe panelists could follow up. Yeah, there are a few questions out there, a few of them already in the public chat and a few that came through. We hope maybe we can try to follow up in an email or, recirculate some of those questions and maybe try to have some reflections through these, email exchanges potentially. I'll check in with you, Norm, and see how that idea would fly. But otherwise, I'd want to wrap things up and turn things over to you, Sara, to close things out.
Sure. And I hate to get in between people and their answers to their questions, but I can be quick. And I don't know if there's time at the end, but I'm here to kind of sum up, I think, and give an outside perspective a little bit to what we've heard. To the extent that's useful, that's what I'm going to do for the next couple of minutes. One of the themes I'm hearing today is across the board about just data proliferation, right? In terms of the types and just the sheer kind of volume of data that's increasingly available to us. No surprise, but people out here have talked about, clinical trials and SDOH, clinical data, test results, vaccination, immunizations, right? Provider data, behavioral health, dental, pharmacy. There's no end to the variety, right? And even as Lisa was saying, the pie's only getting bigger, right? Referring to interoperability, but I think in data, at large as well. In my mind, there's so much promise in that data, and that's why we're all here talking about this, right? Particularly because this is health data, right? We have really high hopes and high stakes for it. How can we make care better? How can we get better at whole person care, make research more efficient, and just understand more about an individual or population so that we can positively affect their health, right? The challenge in my view is like unlocking that potential. And there's obviously we've heard about a lot of the barriers here today too, the challenges. When the data sits, as we know it does, kind of locked away in various systems and owned by various organizations that aren't always talking to each other, the potential of that data gets limited, unfortunately. one of the important challenges at the core of the issue is being able to confidently know whose data is whose. That's what, and I mentioned that mostly because that's one of the things we work on at Verato, and it's close to my heart. But especially in an environment with increasing consolidation and just larger and larger organizations out there, you're more likely to have people whose data that organization is keeping that share names and birthdays and things like that. And so it becomes, more complicated, as you have more pieces of data living in more places, there's just inherently more risk in when you're putting it together, that you're getting it right. Although I'm acknowledging what Kenley is saying earlier about, interoperability is much more than just linkage, obviously. Things like nomenclature, definitions, format, things like that. Next thing, the theme that I think popped for me was incentives. And, Robbie talked about this a lot, but incentives certainly important, right? And needing to align them to make sure that all the right players are working on this. You mentioned the unfortunate, financial disincentives that can sometimes be the reality. And that's striking, right? And something that we obviously need to address larger. We all know that there's regulation and legislation here that's pushing organizations to work on this and make data more portable, which I think is promising, but always takes time, right? But what I think popped here in our discussion today was, we need to continue to work on sharing the stories and getting the word out about what's in it for both, society and the greater good, and also for individual organizations. I think that you were talking about that, Kyle, and also Kenley. In some of your observations too. So, those were the things that kind of popped for me. I don't know if that's helpful, Josie.
Well, great. Well, thank you, everyone. This has been a very engaging and delightful panel. We're appreciative that you could join us today. And let's, well, I don't know how to do this anymore. It's like, let's give a round of applause, but I guess we don't do that with everybody on mute. But I think everybody knows that we appreciate the time they've taken. I put up on the screen here. I hope you can see this one. I hope we got the right screen. What's next? So July 27th, 1 to 4 p.m. We have the next in our Spotlight series on health equity and disparities, the Data Solution Showcase. You can see some of our invited presenters there. We're excited about those. So if anybody on this presentation is listening in is not registered, go over to nato.org/conference and you can find the Spotlight series there and get registered. We'd love to have you all attend and be part of that next step in our series on health equity and disparities. With that, we're going to go ahead and close it up. And thank you to all our panelists again. Oh, by the way, this is being recorded and it will be available on our website probably in about a day or so. So give us a little bit of time to get that processed and uploaded, and we will have that ready to go. So thank you, everyone. We will see you again on July 27th.
Thanks, everybody.
Thank you, Norm.
Thank you.
Thanks.
Thanks, everyone. Bye.